Welcome. My name is Becky Sanders. I'm the Program Director for the Upper Midwest Telehealth Resource Center. And my coworker Amna Anwar asked us to do a presentation for you. Amna, do you want to say anything before we get started?
Hi, I'm Amna Anwar. I'm a Senior Director at Indiana Rural Health Association and the Program Director for Indiana Rural Opioid Consortium. I requested Becky for this webinar specifically because in these times with COVID-19 occupying most of the clinical world, we still have patients suffering from SUD and OUD that still need access to care, and how telemedicine and telehealth can play a role in this is very important, because that's the way most of the clinicians are able to reach their patients. And Becky was gracious enough to accept my request, and she will go into the details of everything that can be done via telehealth.
All right, thanks, Amna. All right, so let's go ahead and get started. I do want to have you take note. We are federally funded under HRSA, and I am not a lawyer. This is not legal advice that I offer to you today. All right, so the Upper Midwest Telehealth Resource Center is under the umbrella of the Indiana Rural Health Association. We are a regional telehealth resource center, one of 12 around the country. You can see the different colors on the map. We cover the states of Illinois, Indiana, Michigan, and Ohio. All states in the United States are covered. The Pacific Basin does also cover the Federated States of Micronesia, Guam, American Samoa, and other U.S. territories. We do also have two national telehealth resource centers, the National Technology Center and the National Center for Health Policy. We have a national website for the National Consortium of Telehealth Resource Centers. There's some resource centers out there, an interactive map that can take you to any of the regional telehealth resource centers or the national telehealth resource centers. We also do have a monthly webinar. Actually going to be talking about COVID-19 tomorrow afternoon at 2 p.m. Eastern. If you go to the UMTRC website, umtrc.org, and go under events, you can register for that there. So this is my 30-second elevator speech about what I do for work. I like to call myself a virtual librarian. So much of what we do, and even with the tsunami of emails and phone calls that we've gotten since the COVID-19 pandemic started, is collation of resources. So we have a ton of resources on our website. We also create our own resources. We connect people with other programs and help telehealth programs to get started and to have strong business models so that they're financially sustainable. All right, telehealth and telemedicine. These terms get used interchangeably a lot. Telehealth is the overall umbrella of telemedicine. It could be used for education, for transferring data, anything healthcare related and data related. And telemedicine is that billable clinical service where you have a CPT code or a HCPCS code, and then you get reimbursement from an insurance provider. Asynchronous telemedicine versus synchronous telemedicine. Asynchronous, a good example of that is dermatology. So you might have a skin rash or a cut or something else that you send a picture to a dermatologist for them to analyze, and then they send back the results and let you know, maybe here's a prescription for poison ivy or, whatever that happens to be. Synchronous is kind of like what we're doing today. It's a live and interactive audio-visual connection between a patient and a provider when they're not in the same place. Prior to the current public health emergency, we always wanted that to be a HIPAA-compliant video conferencing software platform. And there have been some waivers on that. We'll talk about that. But still, as a telehealth resource center, we do recommend that if you're going to do this long term and not just for the next 60 days or however long, that you look into a HIPAA compliant version, and I've got some resources for you about that. The last thing is telemedicine's not a service. You're not going to deliver telemedicine. You're going to deliver clinical services via a different modality of telemedicine, just using technology to help get rid of the gap in distance between a patient and provider for the delivery of clinical services. All right, so COVID-19 hit the United States in March for most intensive purposes. If you are really into research, you can go out to these different policies, read all of these different rules. We're going to try and give you a real quick overview of what's going on today. The CMS website, there's a news alert almost every day. Here in the state of Indiana, I think it's about 2:30 every day. Governor Holcomb is doing his state of the state as far as what's going on with coronavirus, and it varies on time, but the White House is also doing different daily reports. If you want to watch those, I'm sure you can find those. But we're trying to keep up here with all 4 of our states on the different things coming out of CMS. There's been a ton of CPT codes released just for telemedicine, some telephone only codes, because we recognize that some people don't have smartphones or tablets or computers, or just not tech savvy, and all best they have is a telephone. What else? A lot of waivers around supervision, people coming back to the workforce that had retired, students graduating early to be able to provide clinical services. We do have a COVID-19 resource page that we put up on our website. Autumn Daniels, that's helping answer questions behind the scenes, is rapidly collating all of the resources that we find and send to her and putting them out. We do have different state-specific sets of resources that include executive orders and Medicaid waivers as well. So I mentioned HIPAA compliance and relaxing of those rules. This is the latest definition that I've found from CMS, which they clarified in their interim final rule. This was released on March 31st of this year, that the services should be a multimedia communications equipment, including at a minimum audio and video equipment, permitting two-way, real-time, interactive communication between the patient and the distant site physician or provider. So initially Medicare had said, oh yes, you can use telephonic or telephone. And then they kind of stepped back in the interim final rule and said, no, it really needs to be two-way audio visual. And then there are some new codes that are just for telephone services, but they have a lower rate of reimbursement. The CCHP is our National Policy Center, and they've put together some great resources. They've even got a crosswalk between, because there were 2 bills that came out in March. The first bill was mid-March, and then the CARES Act was signed on the 27th of March. And there was changes in those, and then also the interim final rule came out on 3/31. So they've done a great job with a crosswalk for policy, looking at all of the different iterations and what's current as of today. And then I mentioned already our COVID resource page on the UMTRC website. We'll look later at the specific language for Indiana Medicaid as well, and it does allow for telephonic or telephone only. So when we start looking at policy, Medicare pays based on CPT code. It's conditions of payment, and then each state can do their own Medicaid program as they think is best for their individual residents in their state. As of the spring of last year, all 50 states in the nation do allow for reimbursement for their Medicaid programs for live and interactive telemedicine. Only about maybe 20 allow for the asynchronous storing forward. So these are the 4 conditions we always used to spend a lot of time talking about with Medicare. These first 2 have been waived during this national pandemic. So the patient had to be outside of metropolitan statistical area, and they had to be at a designated originating site, a designated healthcare clinical site. So those have been waived. Those were the first things that were waived right around March 17th. And at the end of March, there was 80 new CPT codes added. So those services were expanded, but they did not expand the list of eligible practitioners, which has been an issue, especially with speech and language therapies, physical therapy, occupational therapy, and speech therapy. All right, so prior to all of this, in order to find out if you were an eligible originating site, you'd have to use this data warehouse lookup tool. And it's really based on census code if you're in a rural census tract or a HIPAA, and that has been waived. So these are really huge changes for Medicare, allowing urban sites to be the originating site for telehealth, or even urban individuals, also allowing individuals to receive telemedicine from home has been a huge breakdown, a huge triumph in these difficult times. So the Medicare Learning Network fact sheet is something Medicare puts out every year. They put this out kind of at the beginning of this pandemic, and they did include for this year a specific, I think I got there it is. I had that in a different order. Specific language about COVID-19. So there's different fact sheets that you can go out and look at on the CMS website, and also frequently asked questions. So this is just a snapshot from the Medicare Learning Network fact sheet for Medicare telehealth reimbursement. Mostly it's all E&M codes. So you see all of those codes there. Prior to the COVID pandemic, what we would see is the originating sites, the patient or spoke or originating or rural site would be the patient's location, which would be a clinical facility, and they would bill this Part B facility fee, and it's only about $26. And then on the urban site, or the distant, or the hub, or the provider site, they would bill their normal CPT code, because you're delivering the same clinical services, but with modifiers for telehealth. So right now, nobody's billing, or for the majority of telemedicine, the patients are at home, so you're not billing that facility fee. You're not billing that Q3014. I talked about the COVID outbreak. And I'm going to skip through these. If there are specific questions about CPT codes, we can certainly come back to this. But you're going to get the slides. This resource is available to you. But these are the 80 different codes that CMS added at the end of March to the normal telemedicine code list. And again, these are only Medicare codes. So things like home visits, emergency department visits, initial hospital care, nursing facility visits, intensive care, care planning, neurological testing, radiation, all of these things. Now here's the area where I wanted to point this out, because we've had several physical therapists come to us and say, hey, you know, I have to socially isolate, my patients have to socially isolate. How can I deliver physical therapy? How can I do my job right now? So these therapy services, physical and occupational therapy, all levels, these codes were added to the list of telemedicine codes for Medicare. However, this last bullet here says that the services have been added and can be paid for as Medicare telehealth services, but it does not say that those providers can deliver that service. So that's still an issue that we do not have clarity on yet. I talked about waivers. There's some stuff here on remote patient monitoring. These frequency limitations were also always barriers for inpatient visits, for skilled nursing visits. The inpatient hospital patients could only have a telehealth visit once every 3 days prior to the pandemic, and a nursing facility patient could only have them once every 30 days. So those have been waived, and there's also some critical care consult codes waived. End-stage renal disease has always been something that CMS has paid for when the patient's at home. I want to get to some of these supervision requirements and waivers. So physician assistants, PAs, often have to have supervision, and they have waived all of those supervision rules so they can go ahead and be providing services to patients during this public health emergency. Location waivers. This allows hospitals to have patients off-site and still do normal billing. I know here in the state of Indiana, there's a hotel near the old airport terminal that is being used for COVID-19 patients. Then there's a lot of hotlines, expediting of licensures, allowing folks to continue with their license and extending those types of things. There's also Stark Law waivers, waivers on signature requirements. There's changes to reporting for MIPS, and the accelerated advanced payments are coming into play now with the CARES Act. Here's the link to the full interim final rule and some recent guidelines from CMS about relaxed reporting requirements. All right, so this is really the meat of what we wanted to get to talk about prescribing of controlled substances. So the DEA, for the last couple of years, we've been waiting on some really clear guidance about prescribing via telemedicine. They do have some policies and guidance on their website about electronic prescribing of controlled substances and also for medication-assisted treatment. But what I really want to focus on today here is this change. And let me find the language here. As of, I got to move my video so I can see this. As of March 16th, 2020, and continuing for as long as the Secretary's designation of a public health emergency remains in effect. So they're talking about the Secretary of HHS in the federal government at that level. Then all DEA registered practitioners in all areas of the United States may issue prescriptions for all schedules 2 through 5 controlled substances to patients for whom they have not conducted an in-person medical evaluation, provided the following conditions are met. So the prescription has to be for a legitimate medical purpose, and it has to be prescribed within your normal scope of practice. The communication has to be an audio-visual, real-time, two-way interactive communication system, so no telephone conversations. And the practitioner has to be in accordance with all their federal and state laws. Amna, correct me if I'm wrong. I interpret this last thing as that the practitioner is enrolled or has the waiver from the DEA to prescribe controlled substances and or they're at a DEA approved facility.
Correct.
So what it used to be is you have to have an in-person visit for the medical, and then you could prescribe via telemedicine. So that changes things there and allows you to take on new patients and prescribe controlled substances to them during this public health emergency. So I'm going to stop here and see what kind of questions that we have.
We don't have any questions in the Q&A. I don't see any.
Okay. All right.
Oh, we have one, I guess. Hold on. It says there are some states who do not permit opioids via telehealth, though correct. Indiana has some limitations about initiating opioids, I think.
True. We're really focusing on Indiana today, and around 2017 to 2019, Indiana and Illinois and Michigan and Ohio, all four had changed their rules regarding prescribing of opiates via telemedicine. Most of them, they had various language, but most of them said as long as you've had that in-person visit and it's established a patient and you're prescribing within your scope of practice, it's okay via telemedicine. If there's another state you specifically need guidance on, let me know. Oh, yes, absolutely. Yes, thanks, Polly. The executive orders, yep, we'll talk about those here in just a minute.
And there's one where it says, I thought audio only was now allowed for prescribing controlled substances in Michigan.
That may be true. I prepared slides specifically for the state of Indiana today, and I would have to look that up. If we have time at the end, I'll look that up. Otherwise, I can follow up individually with you. Okay. So focusing specifically for Indiana Medicaid telehealth reimbursement today, I just wanted to show you where to find that information. Indiana Health Coverage Programs, or IHCP, has provider reference modules, and FSSA, Indiana Family Social Services Administration, issues bulletins on a regular basis when things change for Medicaid. This particular document that I'm sharing some screen grabs from was last updated in October of 2019. So from the Indiana Medicaid website, you go under reference provider manuals, and then you find that particular reference provider manual for telehealth and telemedicine. So I gave you a definition, telehealth versus telemedicine. In Indiana Medicaid, they use the term telehealth specifically for home care services. And then they use telemedicine for all of the fee-for-service claims. So Indiana telemedicine doesn't tell you who can do telemedicine. It says who can't. So different things on this says long-term care nursing facilities can't. That has been, I mean, this is what on this page is from October 2019. It's pre-COVID information. So we have had waivers for nursing facilities. We've had waivers for physical therapy. There's been waivers around transportation. That's what right now it's kind of a hodgepodge. You have to see, okay, what's the most current in regulation, in the official rules, and then we're going to have to look at the executive orders and the Medicaid bulletins to get a full picture. So documentation, we get a lot of questions about documentation via telemedicine. It clearly states in Indiana Medicaid that you must maintain documentation both at the distant and originating sites. And you're like, okay, wait a minute, what if the patient's at home? Patient being at home is a waiver during the public health emergency. It's not a traditional originating site. So if the patient wants to take notes, certainly they can. But what they're talking about is the clinical location where a provider or a patient might be, and then the distant site provider at a different location. That's what they're talking about here. So, but you always want to maintain documentation, start and stop times in your chart times, and really this is kind of a CYOA thing. So for reviews and audits later on, that you have proof that the visit happened. So should Medicaid come back at some point and say, hey, you know, we want to review your records, you've got those available. The other thing that we get a lot of questions on right now is a lot of people that hadn't really gotten into the field of telemedicine are now kind of forced into it with all the social distancing that's going on, is appropriate consent. If you are at a larger facility, you might have access to video modules via Epic. And I'm sure that there's other platforms out there that have video modules built into them. Epic is the one that I have experience with, both as a patient and as this being part of my job. But consent, if right now the best that you can do is a telephone conversation or a verbal written consent, then that's what you do. These are unprecedented times. You're going to have to be a little bit creative to meet the main tenets of regulations and do the best that you can. One example of maintaining or obtaining verbal consent is to go ahead and put up a consent form and read it to the patient when you're on your audio-visual connection. Let them read it to them, and then you can send it to them. Some patients may have the ability for you to email it to them and then for them to sign it and scan it back. So you'll have to see, what your patient has the availability for. We do have sample consent forms on our website as well under our resources. So billing and reimbursement via telemedicine, I have not seen, and it doesn't mean it still may happen, but at this point in time, the best I know is Indiana Medicaid has continued asking for the place of service code of 02, meaning that the patient was seen via telemedicine, and the modifier of 95 on that CPT code. So note here, if it contains one or the other but not both, it'll be denied. And you can still use the GT. This is an old modifier that previously Medicaid had asked for, but you don't have to do that. So the basics, what Indiana does and does not pre-COVID-19 cover, live and interactive telemedicine, but not store and forward. Patient consent, we've talked about consent and documentation. We already mentioned that the patient-provider relationship can be created during the first telemedicine event, and that is subject to clinical standards, but that language was put in to law in the state of Indiana back in 2017. And we've already talked about all the DEA waivers. I do want to spend just a moment talking about commercial private insurance. All major commercial payers have come out and said that they will cover copays right now for testing and also for coverage of COVID positive patients. Additionally, if you talk about copays or, if a patient is a HIPAA patient, they have a fund that they're supposed to put their payments into each month. I've lost the words for it. So all of those have been waived by Medicare and Medicaid at this point during this particular public health emergency. And something that Indiana added prior to the pandemic is they did add for Medicaid fee-for-service telemedicine, treatment of speech, language, voice communication. All right, FQHCs and RHCs. I don't know if we have any on the call today. FQHCs and RHCs have a little bit different guidance when it comes to billing for telemedicine. They were already allowed by Indiana Medicaid to cover, to be both the originating and the distant site. So we're good there. But for Medicare, it wasn't until the CARES bill was passed at the end of March that an FQHC or RHC could be the distant site or the provider site for Medicare patients. So that is a big change for Medicare patients. Back to the Indiana Medicaid Provider Reference Manual for Telehealth and Telemedicine. These are some screen grabs. There's actually another provider reference manual specific to FQHCs and RHCs. So if that is your normal practice model, then dig into that and we can follow up with additional questions later. All right, so we've talked a little bit about the COVID-19 resources we've put on our website. We do have an Indiana specific section. And they've got the different executive orders from the governor that have come out specific to telemedicine. You can see those here. The first order came out on March 19th, and that expanded, kind of did the HIPAA waiver and allowed patients to be at home. Indiana Medicaid came out that same day with their bulletin, and it allowed the communication between the patient and the provider to be any real-time interactive consultation, including telephonic, so telephone's okay, in the state of Indiana for Indiana Medicaid, but not text or email. And then just last week, Indiana Medicaid came out with another bulletin that included additional frequently asked questions. Again, our experience over the last 10 years or so is that once you as a provider start providing services via telemedicine, and then also once you as a patient start receiving services via telemedicine, that you're going to like it and want to continue doing that. So with that in mind, we still recommend that you use HIPAA compliant video conferencing products to deliver these clinical services. And if the best that you can do right now during this public health emergency is FaceTime or Skype or Google Hangouts, then okay, fine, for right now, but think long term and look into some of our recommendations for HIPAA compliant video conferencing products. So here are the links where you can go out and get email updates if you want to get email updates of all Indiana executive orders and the health coverage program bulletins. And again, here is the information from the March 19th Indiana Bulletin. Talks about consent and documentation and allows both the patient and the provider to be at home. All right, are there any other questions we need to take now?
There is a question. It says for clinics that are on hospital campuses, that is POS 22, is there a facility fee that can be billed for telehealth under Indiana Medicaid?
I will have to research that and get back to you. I don't know off the top of my head. Yeah, we'll have to do that later. All right, so if the patient's at home, they're not going to have a medical assistant or anyone else to take their vitals. So that's going to be a little bit of a challenge. You're going to have to rely on the patient. Most households do have thermometers, maybe even blood pressure cuffs. If you have a nurse or another healthcare professional in the family, you might have a pulse oximeter or a stethoscope at home. But you're going to have to rely a little bit more on the patient than you would before. You're also not going to be able to palpate the patient. You're going to have to let them tell you how they feel, what they're experiencing, those types of things. That physical exam is going to be a virtual exam. It's not going to be a physical exam. We've already talked about consent, privacy. Here in my home office, I've got the door locked. I've told everyone I'm on a video call, not to be interrupted. But if all you can see is, the 6 feet around me, you don't know if there's another person in the room, and both from the provider side and the patient side. If the provider has somebody with them, you need to talk about that and acknowledge that. I've got so-and-so here with me today. They're helping me do X, Y, Z. If you're the patient and you have a child and you've got a couple parents in the room, you need to acknowledge everybody who's in the room so that the provider has that information to do the best they can during that visit. Privacy, neither the provider nor the patient should be driving a car, should not be in a public space, all of these things. Video etiquette, you want to look professional. I hope you know what that means. And website manner. If you're dealing with something with a patient, like we did several webinars last week for diabetes self-management treatment. A diabetes educator might have plastic pieces of fruit or meat to show portion sizes and plates and those types of things. if it's really, really important, you got a really non-compliant patient, maybe you want to mail that stuff to them at home and have their own guidelines to have that available to them during their telehealth visit. Maybe you have to use, okay, the fist is, 4 ounces, or a deck of cards, or the palm of your hand, or something like that, to use as an example. If you're doing psychology, you're not going to have, you're not going to be able to push a box of tissues to the patient. You might say, hey, before we get started today, do you want to go make sure you have some tissues? Those types of things, to be aware of the situation and talk to your patient in the best way possible and make accommodations for the fact that you're not physically in the same room together. All right, we've already really talked about this, but just as a reminder, when you're doing your billing, you're not going to bill for that Q3014 code for the facility fee if your patient's at home. However, you will be billing your normal CPT code with the appropriate modifiers. All right, that's what we've got for today. What additional questions do we have?
If you have any questions, please type that in the Q&A section. I don't have any, but I would like to revisit the question that was initially asked about prescribing the controlled substances with audio only. There have been, I don't know if it is, there are any specific waivers in Michigan, but what DEA has allowed you to do when it comes to via phone only, there are certain limitations to it. So if you're going to prescribe a controlled substance to a patient that you've already seen, you just need to collect the follow-up information about that patient. That can be done via telephone. It can be done even with only the email or any sort of other medium that you want to use for that virtual consultation, and then issue the prescription. But if you have not seen that patient before, then there are two different limitations. Again, if that prescription is for buprenorphine or any sort of detoxification medication, and you have not seen the patient, that you need to have that initial consult with the patient, which cannot take place via telephone. But if it is for that, if it is not for that purpose, for buprenorphine or for any of detoxification, then the limitation is that you need to have either an in-person evaluation of that patient or via a two-way audio-visual consultation. But if it is for buprenorphine and MAT and all of that, then there is an additional option to use telephone for that initial consultation, and then the prescriber needs to be data waived. So you can use telephone only if you are prescribing that for an already existing patient, or if it is that, if that prescription is for buprenorphine or any other MAT drug and for detoxification. But if it's not for those purposes, then the telephone prescription cannot take place. I think we have another question. It says, in what way do you feel as though cultural competency is followed throughout this whole process of making adjustments due to COVID-19?
That's very true. That is definitely something to keep in mind. I was doing some research for someone else that asked a question about how do you do a telemedicine visit with someone who is audio impaired or visually impaired, has some other type of disability. There are many peer-reviewed articles about that. There has been a lot of research done into that. But yeah, you're really going to have to meet the patient where they're at.
Any other question?
There was an article that one of our coworkers was circulating earlier today. Certainly with all of the social distancing that's going on right now, a lot of people are experiencing more stress, maybe more depressed. So that is definitely an area where therapists can reach out, or behavioral health specialists can reach out to patients while they're still in their home and try and continue services, try and meet those needs. So I'll send that article to you, Amna, and if you want to send it out. We're going to post it as, I think, as a news article and also on our COVID-19 website. Any other questions?
No more questions.
Okay. All right. Well, thank you, everyone. Thank you, Amna, for allowing me to present this for you guys.
Thank you so much, Becky. And if you come up with any questions regarding this, you can always reach out to Becky, and she has provided her contact information, or to me. I can do the same when we send out the slides about the contact information regarding any of the updates that are coming up for telemedicine and for the prescription of controlled substances.
Absolutely. And then you'll be receiving an email from Autumn in the next